Hello, and welcome to SHARE's Metastatic Breast Cancer, cutting-edge research from the National Cancer Institute. My name is Iva Sampaio, and I'm the Senior Director of Programs at SHARE. Before the presentation begins, I'd like to tell you a little about SHARE. SHARE is a 37-year-old non-profit organization that helps people with breast or ovarian cancer, offering the unique support of survivors who've been there. Our services are free of charge and include telephone helplines, in-person and telephone support groups, educational webinars, and public health initiatives. For more information, please visit our website, www.sharecancersupport.org, or 844-ASK-SHARE. Now I'd like to tell you about the format of this program and how you can participate. All participants are muted. This way we can clearly hear the presenter. If you have a question during or after the presentation, please submit the question through the question pane in your control panel. You can access the question pane by clicking on the red arrow in the upper right corner of the screen. Once the presentation is over, we'll open up for questions. I will field the questions and read them to the presenter. Now it is my pleasure to introduce Dr. Patricia Steeg. Dr. Steeg is the Deputy Chief of the Women's Malignancies Branch at the National Cancer Institute. She received her PhD from the University of Maryland in 1982 and currently serves as Chief of the Women's Cancer Section at the Center for Cancer Research. Dr. Steeg discovered the NM23 family of genes, whereby later studies found them to be a metastasis suppressor gene. In addition, she has worked with the Women's Cancer Section to research the role of the NM23 metastasis suppressor gene in breast cancer progression and molecular events involved in breast cancer metastasis to the brain. Dr. Steeg advocates for the shift in both the types of drugs developed for breast cancer and the way in which clinical trials are designed and executed, suggesting that a wider variety of drugs be used in metastasis prevention trials with patients who are at high risk for full-blown metastasis disease. Dr. Steeg, thank you so much for providing us this important information.
Okay, hello everybody. I hope you can hear me. And what I told SHARE, first off, thank you for the invitation to present. What I told them is if you have a question of clarification, if you don't understand what I'm saying, type it in and they can stop me and we can go over it. If it's a question, a traditional question, we'll handle it at the end. All right, so let's start with where we are in metastatic breast cancer. This is an analysis of analyses. So you can follow my pointer. Each line on this table is a set of phase 3 trials, randomized trials, or databases in the metastatic setting. And this shows you how many patients they have. And they analyze the survival of patients with metastatic breast cancer over a certain time period. So starting with 91 and ending with 2001. This study goes later to 2005, 2007, and we're working up to 2010. A little bit about what it was, okay? A single institution database, blah, blah, blah. Here is what we want to see. What was the median survival of metastatic breast cancer patients in these well-annotated databases? Is it improving from these earlier periods to the more current periods? So you're starting with 15 to 22 months of survival. 28 looks like things are getting better, back to 23, back to 21, 23, and now the most current 20. Whether within the range that they looked at, survival improved over time, again, things were looking pretty good there for a while. And they thought, yes, there seems to be improved survival. And I would probably say, hazard a guess at least, that some of this was the improvements in the HER2 and the ER agents. Not so with the more recent studies. And so the very sobering conclusion of this article is that we are not doing better. Patient survival in the metastatic setting is just as lousy as it was quite a while ago. This is 2 studies, again, just background material, of patient survival in the metastatic setting. So this is 188 patients on the left from the Dana-Farber Cancer Institute, much larger European study from the Netherlands, 800 patients. And they've looked at survival from metastatic diagnosis. Here in the blue line, the better survival, the HER2 positives, the hormone receptors, and in the green line, the triple negatives. And it's much the same if you go over to the Netherlands cohort, except here they've done the combinations of HER2 and hormone receptor. So that HER2 positive, hormone receptor positive sits here. HER2 positive, hormone receptor negative is in the green line. HER2 negative, hormone receptor negative, HER2 positive, the blue line, triple negative, the red line. And so what you can take home is that for triple negative, it's still pretty dire. I found this also in the literature. It's from that same Dana-Farber cohort. And it's how many lines of chemotherapy your average metastatic patient is going through. Again, by subtype. And so what you see is that the hormone receptor positive patients, of course, they all have their first line, most a second, most a third, and it just keeps on going through 10 or 11 lines of therapy. Same thing, if not more prevalent for HER2, because we're coming out with more and more lines of therapy, and the presumption is they're having some efficacy and the toxicity isn't too ungodly. But you're looking at a proportion of patients with multiple lines of therapy in the metastatic setting. Not so, triple negative. That's the green line. You're down to 80% here. You're down to 50-some% on the third line of therapy, and you're below 50% at fourth line of therapy. And, is this because the agents aren't working or because they're too toxic? We have no idea. But it relays the fact that we just don't have good successive lines of therapy. All right, so thank you for that introduction, by the way. And it sort of says what's on this slide. And that is, it is really my belief, and belief is belief, but it's based on data, that metastasis can be prevented much better than it can be shrunk by the current therapies. And that could be a prevention of a first metastasis. And many of the metastatic patients say, but you're ignoring us. No, we're not. It can also be the prevention of additional metastases in patients who have limited metastatic disease. I mean, what you don't want is florid all over the body metastases. And this is what we're going to call secondary prevention. But the sobering fact, and this is no more than common sense, is we're going to need new trial designs to do this. So this is the article I wrote now 2 years ago. It has made me friends and enemies. They call it The Right Trials, and it was about can we prevent metastasis. So this is the usual pipeline for drug discovery, the preclinical data, phase 1 trials, this is toxicity and dose finding. Phase 2 trials is some indication of efficacy. It's in the metastatic setting, and so efficacy means shrink the tumors, partial response, complete response. Phase 3 is the trial against standard of care, randomized. Usually then there's FDA approval. And it's only when we then get into the adjuvant setting that we ask something to prevent metastasis. We take high-risk women without detectable metastatic disease and give them systemic therapy and look at time to progression and survival. My point is, suppose a drug won't shrink a tumor in these settings, but it would be perfectly good at preventing metastasis. We would lose it right here. It would not shrink a tumor at phase 2, and it'd be dead in the water. And I believe there are a lot of examples of this. And so what I proposed is we take a time out right here, either before or after, and do metastasis prevention trials. And we've got to do them in thoughtful ways such that they can be accomplished, they'll give a good signal, and they're not going to break the bank. An adjuvant trial breaks the bank. It takes forever, but it does settle the question. And so what I proposed were 2 flavors of metastasis prevention trials. Primary metastasis prevention trial could be an adjuvant setting trial, like we just talked about. Huge and for a drug that has already shown activity. But you could also envision other kinds of primary metastasis prevention trials. Women with an aggressive primary tumor, those who are getting upfront chemotherapy, women with many positive lymph nodes, chest wall recurrences, etc. Okay? When there's secondary metastasis prevention trials, and this is very germane to women who have metastatic disease. These are women with treated and limited metastatic disease, the first metastasis. Okay? Can we find drugs that will prevent the outgrowth of the next and the next metastasis? Okay? And so you're going to randomize your patients, either a placebo or the potential metastasis preventive strategy. The hard part is in combination with standard of care therapy, and that could be pretty variable. But the endpoint in both cases is not shrinkage of a lesion. It is time to either a new metastasis here or the next metastasis there. This is just simple common sense. I can explain this to 5-year-olds. So I'm going to present 2 of the projects that we're working on. I apologize if you wanted an overview of all of breast cancer work. But I'm going to keep this fairly personal and welcome the feedback. So one of the projects that has started from our work on the NM23 metastasis suppressor has been a look at metastatic dormancy. And I'll spend probably 15 minutes talking about what it is. And the real question is, can we drug it? And then the question is, if we think we can drug it, how are we going to test it? And I'm going to really jump through a whole lot of molecular work and tell you that this is the pathway that I want to bring forward potentially for metastatic dormancy. So that this protein, this is a G-coupled protein receptor, crosses the cell membrane 7 times, and it binds a phospholipid called lysophosphatidic acid, LPA, that's in the serum, and then it just signals down. And this receptor has at least 3 names: EDGE2, the LPA1 receptor, or the LPA receptor. And I apologize, I'll try and call it LPA1. But what is it? So LPA is a phospholipid. It's running around your bloodstream right now at ridiculously high levels. Okay? And when it interacts with this family of receptors, it often tells them to move. And so you can get an idea that it could be involved in metastasis. It's a G protein coupled receptor, and all that really means is it's easily druggable. And there are a couple of inhibitors of it. And I'm not going to go into how we got there because that would be a half-hour lecture. But let's just take this as a case in point for can we model dormancy. So here's what we do. We always start with mouse model systems. And this is a model system cut 14-1. It is a mouse breast cancer. And we inject it into the breast, the mammary fat pad of the mouse on day 0 of the experiment. Give them the data recovered from the surgery. and for the injection, and then randomize them either to an inhibitor of the pathway I just showed you. And this inhibitor we started out with is called W0719, or vehicle, whatever you're diluting the 0719. For 8 days, the mice in this experiment got the drug while the primary tumor was growing. We then do a mastectomy on the mouse and keep the drug going. And then we're looking for metastasis at the end. And so you have a vehicle and you have an 0719, and we won't pay much attention to that. Here's the way it ended up. There was no effect when we looked at the 8 days with and without drug on primary tumor size. There was no effect on primary tumor size, which is, again, more evidence that this drug simply wouldn't work in a traditional clinical trial. However, when we looked at metastasis on day 70, the vehicle, the average number of liver mets per section is in this blue bar, and the LPA1 inhibitor is in this purple reddish bar. And you can see a huge inhibition. We also looked in the lung, and again, you see a huge inhibition by this LPA1 inhibitor. So it had no effect on primary tumor formation, but it prevented metastasis. Now, I'm not going to show you a lot of other supporting data. We gave it in the adjuvant setting. We waited until after we did the mastectomies to give the drug. We used it on other model systems. We looked at survival. It's all published. But here's the data I wanted to show you. What we realized is that these tumor cells were escaping from the primary tumor and getting to the lungs and to the liver, but they weren't growing there. And that's what we think is part of what metastatic dormancy is. And so to show that, we stained different tissues with P67. In P67, it's a stain we do on tumors, and it asks whether they're proliferating. If they're in the cell cycle, if they're going through a round of proliferation, they'll be positive and turn green for P67. And here you can see a sheet of primary tumor cells treated with vehicle stained for P67. And so, each of these little green spots is a cell that's proliferating. The blue spots are the nuclei of the tumor cells that aren't proliferating. Okay? If you look at the percentage of green spots between the primary tumor that was treated with vehicle or this LPA1 inhibitor, there is no difference. Okay? But go to the liver and look. And this in the white dotted line is a liver lesion. Okay, so here is that primary tumor growing in the liver. So each of these blue dots is a tumor cell, and those that are co-labeled with green are proliferating. So you can see a good percentage of these cells are proliferating. But when treated with the same inhibitor, while it did nothing up here in the primary site, it wiped out proliferation in the metastatic site. It did the same thing in the lungs while it was at it. And here's the actual data of a whole lot of lesions. So we think that this is metastatic dormancy, or that at least that it is one version of metastatic dormancy. So let's look at what that might be. It's defined as an asymptomatic clinical stage, well known in breast cancer, where metastatic progression is unapparent for years to decades. Okay, and we all know of examples of this. Thought to be caused by a lot of different factors. Cell cycle quiescence is what I just showed you. They stop proliferating. It could be that they don't get a blood supply. It could be that the immune system's holding them in check. But the truth is, in 2014, we have very little idea of what either induces or breaks dormancy. But I think any of us would agree, I hope, that if we could extend dormancy, if we could figure this out and extend it, it's not a bad idea. And so this is another schematic of what dormancy could be. Actually it was from a review that Ken Osborne wrote. So it can either be very slow growth, that, it just takes years to see a metastasis. It could be balanced turnover. In other words, some cells grow and some cells die, and so that they remain small. And it could be they just leave the cell cycle. Okay, and this is actually what I was trying to show you. So many flavors. This is a study that my dear friend Ian Chambers did. This is years ago, 2009, years ago. She had two cell lines. One was metastatically aggressive, and one was pretty much dormant. It would get to the foreign organ and sickle. And she asked a very simple question. What is the effect of chemotherapy on rapidly growing versus dormant metastatic cells? So she took the mice, injected them with either the fast-growing metastatic line, the dormant metastatic line, and then divided them either into vehicle or Adriamycin. Okay? Here's metastasis volume of the fast-growing line. Okay? It works. This is the effect of chemotherapy on tumor volume, metastasis volume. Here is the effect of that same regimen of drug on the dormant cell. And this just absolutely makes sense because it's an anti-proliferative drug. If the cells aren't proliferating, they're not going to respond to this drug. So you have a very minor, non-significant effect. The point is, this is why we're afraid of dormant cells, because they can get past chemotherapy. Cytotoxic chemotherapy doesn't always kill them. And years later, they can come back to haunt us. So I told you to just take for granted that this was the pathway I was interested in. I thought I would explain to you a little bit about this pathway. So the LPA1 pathway is actually under development for a different disease, and that's called fibrosis. Fibrosis is a stroma reaction, and it can be in the lungs, idiopathic fibrosis. We know of liver fibrosis, people who drug users, drinkers, etc. There's kidney fibrosis. You name the organ, you can have fibrosis. And oddly enough, you've probably heard cancer described as a wound that doesn't heal. So is fibrosis. So it starts out with some kind of epithelial damage, and the immune cells come in to start mopping it up. But the fibroblasts in the area of this damage ramp up. So they start making actin and collagen and making all this matrix. And they turn into these super fibroblasts called myofibroblasts. And they are the ones that actually come in and repair the damage. So, if you cut your skin, blah, blah, blah. In a normal environment, you would then heal, and the myofibroblasts turn off. Okay? They just go back to quiescence, and all is well. If they don't turn off, if they persistently are activated, we just keep making more collagen, more matrix, more of these activated cells. And this is called fibrosis. And in the lung, you can make so much fibrosis tissue, fibrotic tissue, that the lungs won't work anymore. And so you can see how it's just a deranged pathway. And indeed, one of the important pathways that drives this is the LPA receptor. So there are a couple of compounds that are of use that are antagonistic to the LPA1 receptor. The preclinical data I showed you was the small Debio compound. It's not orally bioavailable. And if we're talking about dormancy, we're talking about something that people are going to have to take day in, day out. And so we want something oral. So I have entered into an agreement with Sanofi, and this is a compound that is pretty much unpublished, 100842. It is now in phase 2 trials for a particular kind of fibrosis called systemic sclerosis. And there are other LPA1 inhibitors that are in trial for idiopathic pulmonary fibrosis. And so you might think, okay, why would this be relevant to metastasis? And I just want to show you an experiment. So this is an experiment where they took mice. They either did nothing to them or they induced pulmonary fibrosis. There are at least two ways to do it. There's this odd compound called bleomycin you can give them, and you will get lung fibrosis. Or you can irradiate the lungs, and you will get lung fibrosis. If you then take these three animals and inject them in the tail vein with any tumor cell and look at lung metastasis, what you find out is if these mice have fibrosis, so here's the total burden. In the control mice, if they have fibrosis, look how many more metastases they developed. Okay? Here's the number of metastases. The sizes aren't that different. But you can see that fibrosis in and of itself promotes metastasis. And so the idea of inhibiting it and sort of calming down the microenvironment is not a totally crazy idea. So we are working with Sanofi right now in two model systems. This is the one I originally showed you, where we're going to inject the cells, take out the tumors, and eventually sacrifice and vehicle, and the Sanofi compound for 2 different times. This is a much more involved model. It's a tail vein model of metastasis, red being the vehicle and blue being the Sanofi compound. And if all else looks good, we hope to bring this actually to a trial to ask in the triple-negative, hard-to-treat population, will it induce dormancy? So, what is that going to look like? This drug is not going to shrink a tumor, period, end of sentence. And so we're looking at primary metastasis prevention scenarios. These could be women with multiple positive lymph nodes, chest wall recurrences, but we're probably going to go with post-neoadjuvant therapy. And there's, well, we'll leave it. So these would be women with locally advanced breast cancer who got neoadjuvant therapy. And as you all know, you can get a pathologic complete response, and that at the moment portends a better outcome and has been used, although it's now somewhat controversial, as an FDA guidance for approval. But the majority of patients don't get a pathologic CR. There is still some, they responded, but there is still some tumor left. And these would be the patient population that we're considering for this kind of trial. So it would be a post-neoadjuvant randomized phase 2 trial to prevent metastasis, patients with locally advanced primary breast cancers, neoadjuvant chemotherapy without a PCR. And it would be a randomization plus or minus the metastasis prevented, although there is some discussion of will there be a continuation of chemo. With the endpoint, metastasis-free survival. Obviously, toxicity is quality of life, and biopsies of progression so that we can figure out what happened. I'm going to spend the last, and I'm just going to see how much I can fly through, the last 10, 20 minutes on our brain metastasis project, and try and bring you through on what we're trying to do here. So, I don't know about you, but I really, as a metastasis researcher, didn't hear much about brain metastasis until Herceptin came. And all of a sudden, I would hear the oncologist say, and then she developed brain mets. And my head would sort of do a 360 and say, what? But this is what we're learning from doing animal models. Tumor cells go into the brain in the circulation. They somehow get out of the circulation. We'll talk about that. And they often set up shop just outside of the blood vessels. So they sort of co-opt it. In comes, it's not just tumor cells, in come these activated brain cells. They can be astrocytes or microglia, and they come in and probably make the condition a lot worse. And then eventually, these tumors just extend out into the parenchyma of the brain, and you have a brain metastasis. And, you know, everything we try and learn, we start with mouse models. And you could debate all day whether they're any good or not, but other than that, you're just guessing. So what we started with is this one mouse model, these 231 cells. They're triple negative cells. And it's a cell line that's very well known. And Toshi Maeda actually, UC San Antonio, injected them into the heart of a mouse. It's actually a controlled experiment. He got the occasional brain met and was smart enough to take this brain out, quickly mince it into a culture dish, and the tumor cells would grow out of it. He re-injected them. He got more brain mets, and he did this 6 times, 6 rounds, until he got a line that goes to the brain reliably. I hope that is not any of you. Hush. Okay. It grows to the brain reliably and can be used for acids. We have since developed 4 more. And as you can see, pictures of these brain metastases, they're all different. This one's HER2 positive, it's IBC. This is in work that's funded by the IBC Research Foundation with Jenny Mason. Triple negative line, another HER2 positive line, and ER positive line, ER HER2. And so, to define the problem, you enter this huge controversy, and that is that the brain is protected by something called a blood-brain barrier. And this is a series of coverings of the capillaries in the brain, such that things don't get in the brain that you don't want to. And the question is, how much of it is left after a metastasis sets up shop? And there are a number of investigators who say it is gone, because we image brain mets with gadolinium, it has to get in. And if we inject a mouse that has brain mets with a dye, Evans blue, the brain mets will get blue. There are a larger set of people, mostly clinicians, who say, no, 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 no. The blood tumor barrier, which is what's remaining, is still at least partially functional, because chemo simply doesn't work in the brain. And what I would tell you from the mouse perspective is those mets may get blue, but they don't get blue enough. Okay? So this is sort of a diagrammatic cross-section of a brain capillary. So the blood would be in here. Here's the endothelial cell, and it is shut tight. It's got tight junctions. It's surrounded by a basement membrane. These cells called pericytes. There's actually another basement membrane after that, and the feet of astrocytes. And every one of these components provides that barrier function. And the question is, what's left once a brain met sets up shop? So here is one of the neatest experiments we did with a team of pharmacologists at Texas Tech University. So we took our line and injected it into mice and allowed the brain mets to form. Before the mice were sacrificed, we either inject them with dyes or radiolabeled drugs. We give them 10 minutes or so to circulate around, and then we perfuse the mice. That means you run a whole lot of saline through the mouse and wash out anything that's in the circulation. Okay? So only drug or dye you'll see is what was permeable into the brain met. And at necropsy, we made a single section through the whole brain. And we're going to image it 3 different ways, that single section. We're going to look on the green channel because we labeled the tumor cells with green. We're going to look on the red channel because one of the dyes we gave it was red. And then we're going to look at radiation because the drugs we labeled were radioactive. So here is the problem with brain metastasis. Here is a cross-section of a brain. It is filled with metastases. Huge green lesion here and this huge blob. So you see that some of it's very dense, some of it's very scattered. Now go to the same section on the red channel. This is a 3,000 molecular weight red dye. What you can see is that this part of the lesion right here, extraordinarily permeable. The red dye got in just fine. This part, not so much. Absolutely none. This part, well, this part up here was permeable, this part down here not. And if you go the same section, because we gave the mouse not only this dye, but we gave them labeled paclitaxel, you can see the same kind of data. High permeability in this lesion, horrible permeability in this lesion. And so what you find is that brain metastases are heterogeneously permeable. Most of them are a bit more permeable than normal brain, but what we really found is only 10% of them are what we would call freely permeable. And I'll just keep it at that. This is a study that is in press. It is by Andy Simon and Aki Morikawa at Memorial, also Dave Peerboom at Cleveland Clinic, where we enroll just a small number of patients who are coming in for medically indicated craniotomies to an upfront dose, pre-surgical capecitabine. And then we looked at how much capecitabine was taken up into that tumor once it was resected. So if you go just here, 5FU is the active metabolite of capecitabine. And each patient is a different color, and so you can see that the brain met, these are all breast cancer, from the blue patient took up 2 micromolar. The brain met from the red patient was at 4. Well, here you go down to the 4 green patient who was at point something. And you see the same heterogeneity in a patient-to-patient basis now in the human. And what it tells you is that the model is, they're never 100% right, but it's on target. So here's what we've been trying to do. We inject these tumor cells. It's into the left ventricle of the heart on day 0. On day 3, we have just started putting drugs into these animals. And we keep it going. It's about a 1-month action. At the end of the month, if something has worked, okay, we actually count the number of metastases in the brain, that will have prevented metastasis. Okay, it's the easier bar. If it looks decent, what we then do is wait until the metastases are formed and then start dosing to ask, will it either shrink them or prevent more from forming? And that's what we call a treatment experiment. So prevention of brain metastases, treatment of brain metastases. We always do prevention first. And this is from a CCR review I just authored that lists a whole lot of work that was done by Diane Palmieri. And all you have to do is look over here at percent reduction in brain metastases. We actually had some luck with gemcitabine, and this deserves some additional inquiry, although it had absolutely no effect on micromets. I have a feeling it's going to be short-lived. We had some luck with lapatinib, vorinostat, zokinib, and a paclitaxel conjugate, supposedly to get in the brain better. Okay, so these, we had a preventive effect. Did we have a therapeutic effect out of any of them? No. Okay, nothing. So this brings up the idea that we can prevent metastases much better than we can treat them. And again, I can explain this to a 5-year-old. If you have a detectable metastasis, we're talking about millions of tumor cells. Okay? If you're talking about preventing it, you're talking about either a single tumor cell or a bunch of tumor cells. Call it a field. So here you have to impact millions of tumor cells. Here you only have to get to a few. This, by definition, has a tortuous blood supply at this point. We don't really know much, but we think that this is a more normal blood supply. So drug delivery ought to be better. Here you have to kill the tumor cells to shrink the lesion. Here, a cytostatic inhibitor to keep it dormant. Okay, you don't need to kill it, you need to tell it to sit still. And because of this blood supply and edema, drug delivery is thought to be very difficult here, and it's probably better. So this is just a common sense thing that says prevention should be easier. And then, so the question is, how are we possibly going to test these preventive agents? And this is sort of the way we do clinical trials now in the brain. Most of the trials are progression after whole brain radiation therapy, after the patients have progressed on this. Most of the trials, it's easy to recruit because there are very few options left. The endpoint is shrinking lesions, heaven only knows. Concurrent with whole brain radiation therapy. These are the elusive radiation sensitizers. Will it shrink more lesions? You could think about preventing brain metastases in the metastatic setting. It would be time till a brain met. The problem is it's going to be a long trial. It's going to cost a fortune, and we're not sure who to enroll. And so what I am proposing strongly is a secondary prevention trial. This is prevention of additional metastases in patients with limited brain metastases. The endpoint is not shrinkage. It's time to a new brain metastases. And I think there are a couple of compounds we've tested preclinically that are good candidates for this. I want to show you the work Diane published earlier this year, with temozolomide. Temodar is the first-line treatment for glioblastoma. So these are primary tumors of the brain. It's brain permeable. It will get past that blood tumor barrier. And it has been tried in one trial to shrink established brain metastases where it failed miserably. Here we're asking, will it prevent? And so we started with a dose well established in the literature of 50 mg/kg. And what you're looking at here is in this experiment, this is the number of large metastases in the temozolomide arm, the control arm, the p-value. Nothing. No micromets. We couldn't find a thing in those brains. We repeated the experiment. Nothing. We took down the dose. Nothing. We repeated it. Nothing. We took down the dose. Nothing. We're now at 10-fold less. Nothing. And it wasn't until we got to 100-fold less that we lost significance in preventing the formation of metastases. This is in the 231 cells. I've never seen anything like it before or since. This is actually a lifespan survival experiment where the mice were either given a short course of vehicle, temozolomide, or later temozolomide. Vehicle mice died. The early temozolomide was clearly best with about 60% of the mice. We then just let them run around with no further treatment for about a half a year. And you can see we had a lot of long-term survivors. And as with the clinical trial, it's ineffective if given late. So here's vehicle and day 24. It just did nothing. So this is what I have been working with SWOG on. It is a randomized secondary brain metastasis prevention trial. Christina Tien, who is now at Wisconsin, I believe, not Michigan, for SWOG is the PI. The enrollment is going to be HER2-positive patients with 1 to 3 brain metastases that have been treated with SRS or surgery, no whole brain radiation therapy. They are at very high risk to develop new metastases fast. We're going to use TDM1 as the systemic therapy, because we clearly have to treat every lesion. And we're going to then randomize them to a metronomic low dose. That means a low dose given almost daily of temozolomide or not. The endpoint is the time to the development of a new metastasis outside of the SRS beds of the original ones at 3 months. It's not shrinkage of the lesion, clearly toxicity, clearly quality of life, and clearly time to they need whole brain radiation. We've drafted a phase 1 run-in because this combination has not been tried with Genentech. If you have any muscle. What has stopped this trial dead in its tracks for 1 year is the fact that temozolomide has gone off patent and Merck is refusing to give it out for clinical trials. It will cost about $4 or $5 million for this trial. It's not a cheap drug. We've tried, there are 2 generic firms making the drug, and the price has not dropped. It is a travesty. Happy to talk to anyone who can help us out. Okay, I then want to take just a couple more minutes and go through 1 or 2 other developments in the field. This is the Landscape trial. It is published. It was an earlier trial using lopatinib and capecitabine as first-line treatment for brain metastases. And you can see a very nice survival curve with a lot of patients experiencing volumetric reductions. And because of that, there is a second secondary prevention study that's being organized. This is being done by Manesh Mehta at the University of Maryland, and he calls them window of opportunity studies. If I have brain metastases, I don't really see that as an opportunity. But it's a phase 2 trial of lopatinib capecitabine in patients with brain mets locally treated. Same idea. So we'll get 2, hopefully 2. I'm going to skip over this. I do want to alert you, I think this is a very positive development. There are criteria that are going to come out. This is now submitted for publication, I believe. They're going to be called RANO criteria. This is work that is headed by Nancy Lin. And the idea is that when we use RECIST criteria on regular clinical trials, they will measure a couple of indicator lesions, which usually aren't in the brain. They're in the liver, the lung, etc. And you never find out what happened in the brain. And we've all learned now that it could be very different. And so what they are going to propose is that clinical trial data now be reported as 2 sets. RANO criteria, what happened in the brain? Was it a CR, a PR, a stable disease, progressive disease? And what happens systemically by RECIST? Okay? And so we are going to start learning what is active or conversely inactive in the brain of patients and get some more information. I think this is a very positive development. What else? The last thing I want to show you is a nomogram that was published by MD Anderson and JCO. And this is a nomogram that's very easy, that predicts probability of a brain metastasis in patients with metastatic breast cancer. I'll just give you 2 examples. So the patient in blue was this old, had a histologic grade of this. Here it was HER2 positive. Here's the age. And this is the delay between diagnosis and first metastasis. And you add all of these numbers up and you come up with the probability of brain metastasis. This would be a different patient. In the yellow lines, age, the same criteria, you come up with a very low probability. And I think it is very likely that we could use this kind of nomogram to identify patients at very high risk. And that would be another way to do primary brain metastasis prevention strategies. In closing, if you have not seen the site, I wish nobody had to go there. But there is a phenomenal website, FamousPC.org, that was started under the auspices of a DoD grant. It was run by Musa Mayer and Helen Schiff from the late Leela Romeo. And I just wanted to make you aware of it. And then there are too many people to thank, and we're going to run out of time. So what I think I'll do is just turn it over to questions at this point. I hope this was at least a perspective on where we should be going. Thank you.
Thank you, Dr. Steeg. We really appreciate all the information that you covered today. And I know it's quite a bit. I want to let people know that they can get the information and your slides on SHARE's website. A few questions have come up. One of them is asking, please tell us what kind of research is being done to provide treatment that would contain metastatic disease so patients could live with the disease for 20 to 30 years. And I guess that speaks to the tumor dormancy.
It speaks to the dormancy, and it speaks to the secondary prevention idea. These are patients who have limited metastatic disease, and we want to stop it there. And I think both of these strategies do not ignore the metastatic patient, but are actually, aiming to stop this kind of proliferation of lesions. And I will add, the SRC inhibitors that have recently been discontinued by a number of companies, these were probably great metastasis preventers. The TGF-beta inhibitors, I suspect, will do the same thing, but they are dying in phase 2 trials because they're not shrinking tumors. So here are opportunities to do exactly what is being asked that I think are being lost. The integrin inhibitors, same thing.
Okay, so someone else is asking, are many other researchers working on prevention of metastatic disease?
Well, yes and no. Everyone who does a metastasis assay is probably working on preventing, because that's the endpoint in most of them. But we don't make that lead to trials. We then just hand off the data to a drug company who puts it in a phase 2 trial. It doesn't shrink a tumor and it's dead. And they all say, oh, models don't predict. And so, I just named the SRC inhibitors, the integrin inhibitors, the TGF-beta inhibitors. I think they all will prevent. There's great preclinical data out there, but the trials are not being done that will see that signal.
Thank you. Any updates on the Mammoglobia A vaccine trial?
I don't know what that is. I'm sorry.
Unfortunately, I don't either. Okay, so we'll move on to the next question. We will find out for you and then respond. Can you discuss where the medical community sees cannabis oil and turmeric in the treatment of metastatic breast cancer?
To my knowledge, there's no level 1 data on either of those, but I'm not an expert.
Okay. And also, someone else was asking about liver meds, if you knew of any new research.
So there are a number, particularly for instance, in bladder cancer, where liver mets are very common. There are more and more people revisiting surgery for limited metastases. And they are then randomizing these patients, because there certainly is a risk of relapse, to secondary metastasis prevention trials. In bladder, this is being done by my friend Dan Theodorescu in Colorado. Steve Labuti is doing trials like these. These are mostly surgical trials, but I actually am following them with great interest to see if something will prevent additional liver lesions from popping up.
Thank you. Let's see. Someone else is asking about, they're stating that they're especially interested in new therapies for metastatic breast cancer that are not chemotherapy treatments.
Yeah, we all are. And every one of these things I've described, the fibrosis inhibitors, SRC, TGF-beta, these are all molecular therapies. We are approached by more companies than I can count. Bruce and I had this conversation. Why would anyone want to get paclitaxel in the brain? Who have tried to brain permeabilize paclitaxel. And I have minimal, we have an interest in it. We have an open trial here. But I agree that the future is in these molecular therapies. However, you've got to understand that the minute you hit a tumor cell with a molecular therapy, its entire job changes to get around it. It's sort of a life and death issue. And so there's always going to be resistance. And I think down the line we're going to have to take the strategy that worked in AIDS. It's going to have to be a combo of drugs, and we're just not there yet.
Thank you for that response. Another asks, are we doing any research regarding nutrition or building the immune system to fight metastatic disease?
We're doing a heck of a lot on the immune system. I was just in a brain metastasis teleconference this morning on immune checkpoint and brain mets. But unfortunately, I mean, my look at the unpublished data is that while melanoma and lung cancer brain mets are full of these markers, breast cancer isn't. And so to what extent that is the same systemically, I don't know yet. Clearly the poster children has been melanoma. But yes, people are working very hard, particularly now that we have some drugs. The efficacy in breast cancer, to my knowledge, remains unestablished.
Thank you. Someone is asking if someone with brain mets that went away with radiation, HER2 negative, are they eligible for your possible clinical trial?
Probably. I mean, I defer to Christina, but it sounds right.
Okay.
Because I think this person would still be at risk.
Okay, thank you. Someone else is asking, is the reason endpoints of clinical trials is shrinkage because most phase 3 trials on metastatic breast cancer patients are done to find a drug that can be brought back to early stage breast cancer patients?
I don't know. I mean, shrinkage, I mean, I get the fact that we all want lesions to shrink. I don't know how it evolved that way. I'm not a student of clinical trial history. The only point I keep making is it's not the only endpoint that we should have in our quiver. I mean, there are times when it's not the right endpoint. And I seem to have a whole lot more luck talking to the Europeans about this than I do American docs. You know, you hear a lot of, well, this is the way it's been done, this is how you build a career with that. I've heard it all. And I just keep flying across the ocean to present this stuff to various European countries. We're stuck in our ways.
Okay, so we have time for one last question for you. Which do you think are the most promising metastatic treatments in later stage development?
It's hard to say because it really depends on the subtypes. I mean, and my opinions don't really matter because I'm a PhD, it's only my opinions, not the NCI. I'm very interested in CDK inhibitors or ER positive. I'm interested, Musa has beat into me the word side effects. You know, you've got to have efficacy, but if it's going to give you pneumonia and make you feel like you're half dead, I'm not sure we've gotten there.
Well, I'm sorry. I think this also speaks to the other question that we received. So I think if you could answer quickly with respect to the side effects of the LPA antagonist.
So it's been through phase 1 where it was absolutely milquetoast. They never got a maximum tolerated dose. And in the phase 2, it's still under evaluation, but from what I hear, it's looking good.
Can you repeat that, please?
Can
you repeat?
The phase 2 data aren't out yet, but the phase 1, they couldn't even find the maximum tolerated dose because there weren't hardly any side effects. So it's looking good.
Okay, well, we'd like to thank Dr. Steeg for a great presentation, and thank you all for your participation. Please take the time to complete our short survey and let us know how we're doing. Don't forget to visit us at our website, www.sharecancersupport.org, and a recording of this webinar will be available online. You will be notified when it is ready to be viewed. And once again, thank you, Dr. Steeg. I know you're doing some very interesting and important work, and we appreciate everything that you're doing at NCI.
I just want to thank Cher, and I want to thank all of the advocates who have helped me so much over the years.
Thank you.
Okay, thank you. Bye all.
Bye.
Thank you.